Assalamu alaikum, and thank you, Mr. Moderator, for the introduction. So I'll be talking about the role of trimodality, some updates in bladder cancer, in which patients that we should consider, and whether there is any role for the conservative management. So I just deleted some of the slides because the moderator first talked about the incidence in Bangladesh and globally. So I'll concentrate mainly about the trimodality as an option, when to consider some conclusive remarks. Just to mention, it is not that common in Bangladesh, the bladder cancer. Luckily, it is the 18th, as was mentioned earlier. So when we have a muscle-invasive bladder cancer, mainly TCC, of course, so the options are there. The standard of care, we know that for many years it was cystectomy, and but we're looking for the other alternatives to preserve the organ. And our aim, actually, to cure patients with the optimal survival and prevention of pelvic failure, distal metastasis, and to have a good quality of life. Now, if we succeeded in many cancers to treat it without surgery, like Dr. Nadeem mentioned about the prostate cancer and the other cancers like the anal cancer, esophageal cancer, in some cases laryngeal, and prostate and rectal, why not in the bladder? So what evidence we do have, and in which cases? So for many years, surgery has been the standard of care, but now we have more and more evidence in literature to tell us that trimodality approach can lead the same results, whether disease-free survival or overall survival in some cases of bladder cancer. So this option should be offered to patients, not only to consider surgery. It's the right to the patients, it's his right to know about the options that they are there. So, and of course, when we say about the trimodality, it is the maximum TURBT, which is very important, and then concomitant chemoradiation. Now, this is one of the good publications from Mass General Hospitals, because they are known for their research in the trimodality. It's an updated analysis from Mass General Hospital about the long-term outcome after bladder preservation therapy, and they have shown that with time, from 20 years or more till today, the advances are there in trying to control the disease by better understanding the patient selections, and also the advances in radiotherapy technology, at least for the to lessen the side effects, because the dose have been, roughly speaking, the same, and also the importance of the maximum TURBT. And you can see here that the disease control with years have been improved. And this really summarizes about the 5 years, the 10 years, disease-free survival and overall survival. And you can see with the trimodality, the overall survival reaches up to 75%, which is even same as surgery, if not better. And with the disease, also specific survival at 5 years is 84%. So, you can see here, it is logic that the T2, the results is better than T3 and T4, although it is still indicated to consider trimodality in T3 and T4 diseases, even with N0 or N1, and also not only the disease-free survival, but overall survival, the T2 is much better, the results, than T3 and T4. Now coming about the importance of TURBT, that's why the treatment of such a disease, like in the other cancers also, it should be done within the multidisciplinary approach manner, because the role of urologists, even we consider the trimodality, is very important. From step 1, that is the maximum TURBT. So this will lead really to a good results which can match the surgery. So TURBT, you can see here in the right side about the importance of the disease-free survival when you have a maximum TURBT or a less TURBT. So it has, a reflection on the outcome for the overall survival and for the disease-free survival. So this is really very important. They concluded from Mass General Hospital, because they have published a lot of cases in trimodality, that these data demonstrate a high rates of complete response and bladder preservation in patients receiving the trimodality, and this it's similar to the cystectomy series. And this is really, now we do have an evidence to say that in selected patients, and this slide is very important, which patients really can give you good results by the modality as if you are doing surgery. So patient will preserve his bladder. Patients with solitary T2 or early T3, less than 6 or 7 cm, the no tumor-associated hydronephrosis, so patients can go for chemotherapy, and also the maximum visible 2-RBT, which is very, very important, and no carcinoma, extensive carcinoma in situ. And of course, adequate renal function, allowing the patient to receive the cisplatin and the TCC histology. We are not talking about squamous, the very rare one, or adenocarcinoma. We are talking about the maximum, what we see, the majority of the TCC. So if you have a patient with these criteria, probably you have to offer. It is the right of patients to know that there are other options than surgery, which is a trimodality. Now, this is a systematic review and meta-analysis on the oncological long-term after the trimodality. And although it was published in 2017, but this is really a major one because they studied about more than 3,400 patients who underwent the trimodality and with surgery, around 26, because it was at that time it's standard of care, so a lot of cases are there. So when they compared both and the balance in the tumor characteristics, irrespective of the dose and how the dose of radiotherapy, which was given, whether it is a split or the concomitant full course of radiotherapy, that again, the survival outcome patient after the trimodality and surgery for the muscle invasive were comparable. So we do have evidence in literature to support the trimodality in selected patients. Now, for those patients who will go for trimodality, what's the percentage that they will fail, and then they may need a salvage cystectomy? So in this meta-analysis, more than 73 studies, compromising more than 9,000 patients, the rate was almost 20%. This means that 80% of patients who underwent a trimodality, still they live with bladder and without any salvage the surgery. And this information can be shared with patients during discussion, that probably if you go with the trimodality, the chance to have a salvage surgery would be around 20%. So let's see about the international guidelines and where the trimodality fits there. The NCCN, the American AUA or ASCO or ASTRO, and the European one, the EUA and ISMO. You can find it here clearly in the latest report of or guidelines of the bladder cancer with the NCCN, that it is an option there to go for a neoadjuvant followed by surgery, which is standard of care, or it is the bladder conservative, and it is category 1. So it is like surgery category 1 in selected patients. Even for the T3 also disease, or T4 with N0 and N1, still it can be considered the bladder, and again it is category 1, as you can see here. Now, looking for the other guidelines, which is a common guidelines by AUA, ASCO, ASTRO, and the SUO. Again, you can see here after the diagnosis, after the MDT discussion, still the trimodality in selected patients can be offered as a first line of a treatment. And they recommended in this American guidelines, the common one, that for patients with a newly diagnosed muscle invasive who desire to return their bladder, and for those with significant comorbidities for whom radical cystectomy is not a treatment option, clinicians should offer bladder preserving therapy when clinically appropriate. And in patients under consideration for bladder preservation, maximum TRBT is really very important, and then you have to see whether the patient has extensive carcinoma in situ or not, because if it is there, then trimodality is not an option. Again, if you see in European guidelines, the common ISMO and the EUA, the same like the American one, it is the same, the tri-modality, it's mentioned there in the muscle invasive, with a strong recommendation and strong rating to consider the tri-modality for those patients. And again, they're talking about the importance of multidisciplinary approach reaching to this decision, and also the importance of maximum resection. So radiotherapy, we know it's up to usually 65 or 66, or in 55 and 20 fractions, giving to the bladder with the pelvic lymph nodes as a prophylactic if they are negative, and then boost to the bladder. Usually it's being done by VMAT or IMRT, better than probably the 3D if you have the VMAT, better the conformity and less time for treatment. In VMAT, hardly 2 to 3 minutes only. And that needs really a follow-up cystoscopy just to catch any early recurrence or persistent disease where you can consider surgery for those patients. And you can see here about the plan using the VMAT for such patients. Usually we do it with the empty bladder. To conclude, tri-modality is the standard of care in patients who refuse surgery or medically unfit patients. But in selected patients, as I mentioned, you can still preserve the bladder, and only the need for salvage surgery is 20%, and this should be offered to your patients if you select it very well, as we mentioned. And in general, as we do and as we have to do, we have to discuss these patients in multidisciplinary team approach. Thank you so much.